Good evening, dear participants, and we would all like to welcome a very senior faculty with us today. We have with us Dr. Girish sir. Sir has specialized in pediatric critical care as well as pediatric cardiac critical care, and sir has worked in many of the prestigious hospitals abroad as well as in our country. And sir has many publications to his credit as well. Good evening, sir, and we are very happy to have you, sir. And today's class will be on approach to inborn error of metabolism. And as it's a very difficult topic for all of us, and today, sir is here to simplify the topic to us and teach us as much as possible regarding this topic, sir. Thank you, sir, for coming, sir.
Okay. Shall I start, Dr. Naglata?
Yes, sir.
Yes, yes.
Yeah. At the outset, I would like to thank Dr. Naglata and the entire team of White Army. Actually, I didn't realize that there was an RCB match today. Otherwise, I would have said yesterday. But anyway, somebody can keep updating the scores. So, I think they are winning. Since Dr. Naglata told me that this is a educative platform for undergraduates, postgraduates, as well as clinicians, it was very difficult to put together a talk which caters to all the three. But I have tried my best. Hopefully, it will be useful to everybody. I'm audible, right? I'm fine. Voice and all is fine.
Yes, sir. Everything is
okay.
fine. Everything is fine.
Yeah. So basically, sorry, next. Is it moving? The slide is moving?
Move ಮಾಡಿ sir ಒಂದ್ಸತಿ.
I am moving. Yeah, one second. Yeah.
Yes, sir.
It's moving now?
Yes, sir. Yes.
Yeah. See, the first terminology of inborn error of metabolism was actually coined way back in 1908, almost like 125 years ago. And this was by Sir Archibald Garrard. He was a physician in UK. So what he did was basically gave a talk about, and after discovering these four diseases, mainly albinism, alkaptonuria, cystinuria, and pentasuria, these four diseases he thought had a genetic origin and had errors in metabolism. And this was the first publication which was presented at Royal College of Physicians in 1908. And this has 182 pages about four diseases only. So you can imagine how detailed the investigation of these four diseases were. Even at that time, he realized that, these four diseases were only tip of the iceberg. There probably are many diseases which are not discovered at that time. And even today, 125 years later, what we know, IEM, probably we know about 600 to 800 IEMs, known IEMs. But even they are probably tip of the icebergs, because not only in infancy, not only in newborn, not only in childhood, probably there are a lot of diseases, which have inborn error of metabolism as a causative factor. For example, if you have a patient with, say, unketogenic diet to lose weight, we do hear that some of them don't do well. That's probably because they may have some defect in ketogenesis. So that's why probably ketogenic diet will not work for everyone. So what we know today, even 125 years after the first discovery of IEM, it is still only tip of the iceberg. Oops. One second. There's some problem with the. Okay, there is some issue with this. Okay, so that is why, in last 125 years, this field of inborn error of metabolism has expanded so much. And as you can see, lot of these textbooks are more than 1,000 pages. So there are so many textbooks about genomics, about IEM. So we have a lot of information, but still, I think we probably have a long way to go as far as IEM is concerned. So to cover all these 2,000 pages of textbook in 45 minutes is extremely difficult, particularly when the audience is as varied as here. undergraduates, postgraduates, and clinicians. So what I would, as a broad outline, what I'm going to cover is one, basics of human metabolism, because if we don't know biochemistry, we will not understand IEM as much. We will cover a little bit of basics of human metabolism, and why and when should you suspect IEM? How do you investigate the suspicion once you suspect? How do you approach the emergency treatment before even getting the specific diagnosis? And once we make a specific diagnosis, how do we approach it? Definitely, because of lack of time, I will not talk about any particular diagnosis or particular case presentation. Maybe that's for part 2 to come. So first, starting with basic human metabolism. See, unless we know the basics, we will never get to understand the pathophysiology. We need to know the physiology first, then we can understand the pathophysiology. So all I'm going to today, to bring you back to medical college dates, we always, when we joined medical college, I don't know what all others did, but I bought Harper's biochemistry book. But after a while, I understood that, probably I should just stop reading it, because biochemistry was not so attractive as much as physiology was. And I'm sure a lot of people here and undergraduates and postgraduates, this is what their expression was when they started reading biochemistry. And by the time exam came, we stuck to Ram Rao textbook of biochemistry, a smaller Indian version. So biochemistry was not very attractive, but to be honest, I can safely say that after taking care of IEM patients for last 20-22 years, my understanding of biochemistry is much better today than when I was in first year MBBS. That's because the application of what we studied at that time, when it is relevant to clinical medicine, it makes more sense. So I'm going to simplify the biochemistry for you. This is what we are going to do. We are going to dissect out each enzyme here over the next 45 minutes. I'm just kidding. I can't do that, right? I mean, look at this. Look at this slide. I mean, this is human biochemistry in one single slide. You have carbohydrate metabolism, amino acid metabolism, vitamin and cofactor metabolism, purines, nucleotide and protein metabolism, fatty acid metabolism, Krebs cycle, urea cycle, all those things, right? So we don't need to understand every enzyme that is there in the body, but we need to have a broad outlook of what the human metabolism is. That's what I'm going to justify this, entire human metabolism in the next few slides, at least 8 to 10 slides, so that we understand the disease better. So basically, what is relevant to understanding the IEM? What should we know about human metabolism to understand the IEM? First, we need to understand the primary energy source in the body is glucose. It's carbohydrate, that too it is glucose, right? So glucose metabolism is the primary energy source. And of course, glucose, we constantly ingest carbohydrate. We eat at least 3 times a day. Some people maybe 6 to 8 times a day, but 3 times a day for sure. And even when we are not eating, glucose is released by glycolysis, gluconeogenesis. And when these things run out of stock, then we go to fatty acids. That fat are metabolized, and that will be energy source. And of course, amino acids are very important for making up. It is not so much an energy source in normal circumstances. It is mainly for building the human body, but under certain circumstances, it can be a source for energy. And of course, the clearance of all this through amino acid, through glucose, through fatty acids, we create 2 types of waste. One is the nitrogen waste, which goes out through the kidneys. And the other one is carbon waste, which is carbon dioxide, which goes out through the lungs. So in a nutshell, this is what the human metabolism is. But to understand IEM, we need a little more than this, right? This is just a broad overview of what happens in the body. And Krebs cycle is the final pathway for all for energy, energy production. Now, this is a metabolism summary. So what happens? Carbohydrates, glucose is the main source. Even when we are not eating, we are giving constantly the source of glucose. The body kicks in with breaking the glycogen. If that doesn't work, body will produce glucose through other mechanisms, gluconeogenesis. And ultimately, when the glucose is metabolized, it leads to lactate, pyruvate, and lactate, and this enters the citric acid cycle and produces energy. About proteins, when they're usually used for growth and body building, but when it is broken up, there is a constant breakdown of protein normally also. Nitrogen and carbon waste is created, and nitrogen is taken care through urea cycle. And of course, the carbon ultimately gets into this acetyl-CoA and citric acid cycle. Similarly, with the fat, when the fat is broken down, you break down into fat, glycerol and fatty acids. Again, glycerol somehow enters the pathway here and gets into citric acid cycle. And of course, fatty acids also through fatty acid oxidation gets into the citric acid cycle. And ultimately, the purpose of citric acid cycle is to charge the electron transport chain in mitochondria and produce energy. So this is what is the normal metabolism is. Now, this is gist of things which happen where, for example, this rectangle, this is the mitochondria, and this is outside the mitochondria is the cytoplasm. So all your glycolysis happens outside in the cytoplasm. Your lipid metabolism, free fatty acids are released in the cytoplasm and then enters the mitochondria. Glucose metabolism enters, pyruvate enters the mitochondria, and proteins, again, amino acids are broken down and that enters the mitochondria to this citric acid cycle. So ultimately, this is where the energy is produced. And of course, fatty acids are degraded into ketogenesis, ketones in the mitochondria, and it is released into the body. A small quiz for postgraduates here. Which is the tissue with the highest mitochondrial density in cells? I mean, you can just answer yourself. I think everybody is muted here. So think about it. I'll give you an answer in next 10 seconds. The tissue with highest mitochondrial density in cells. You can put it in the chat if you know the answer. Liver. Somebody has written liver. No. So it's actually muscles. Muscles are the one with the highest mitochondria. That too, heart muscles particularly. It's almost 5,000 mitochondria in a cell. And that explains why in most of the mitochondrial diseases, you have myopathy, including cardiomyopathy. We'll come to that later. But because the mitochondrial density is so high, it is dependent on that. Most of the mitochondrial diseases are always associated with mitochondrial myopathy, mitochondrial cardiomyopathy. Now, as far as amino acids are concerned, as I said, amino acids are not normally called in to generate energy, but under circumstances, they may be called in to generate energy. And the way they do is, there are a lot of amino acids which are ketogenic, and there are lots of amino acids which are glucogenic, and there are some which are both. So ultimately, amino acids are used for the body building, but some of the amino acids may provide you either ketones or glucose through gluconeogenesis. And it produces two ways, ammonia and carbon skeletons. Ammonia is removed from the body through kidney as urea, through urea cycle. And carbon skeletons can be used to produce glucose. It can be used to produce ketone bodies. It can be used to produce fatty acids. It can be used to produce ATP through Krebs cycle, or it can be used to produce special things like cholesterol and bilirubin and all those things. So this is, I will not go into the details, but as I was telling, there are some amino acids which are ketogenic, some amino acids which are glucogenic. The red ones are ketogenic, the green ones are glucogenic here, and the blue ones are both glucogenic and ketogenic. You don't need to know particularly which one is ketogenic and which one is glucogenic. Maybe IEM experts need to know. Now, as far as fat is concerned, as we know, fat is generally as a storehouse, used as a storehouse. But when glucose is not available, body has to break down fat, and body breaks down the fat, but not all organs use fat directly. As we know, fat is broken down into fatty acids and glycerol, and glycerol enters the pathway somewhere in the glycolysis area and it is used. And fatty acids cannot be used directly by the tissue. For example, brain cannot use fatty acids, but what brain can use is the ketones. So when the fatty acid oxidation happens, it mainly happens in the liver, and liver releases the ketones into the blood. But liver is a great sacrificer. Liver releases the ketones, but liver can never use the ketones. Liver can only use glucose or fatty acid directly, not as ketones. So which are the organs which can use the ketones? Heart, brain, muscle, but not the liver. So all these organs can use the ketones. So this is about ketogenesis. That is how it is produced. Basically, we know that acetoacetate, acetone, and beta hydroxybutyrate are the main ketones in the body, which under fasting state, body uses ketones. Heart, brain, muscle, everything uses ketones. This is another same thing. I mean, I'm just reiterating these points so that it becomes easier for us to approach IEM. So again, here, what it is showing here is basically your fatty acids. This is in the liver. The fatty acid is broken down into acetoacetate, acetone, and beta hydroxybutyrate, which are ketones, which are released into the blood. And this is mopped up by your muscles, renal cortex, brain in prolonged fasting state, and it is used as an energy source. Now, when the fatty acids are broken down and ketones are produced inside the mitochondria. But unfortunately, fatty acids cannot enter the mitochondria without a co-transporter, which is carnitine. That is why in a lot of IEM diseases, carnitine is at the center. In the sense, it is an important mechanism by which fatty acids enter into the mitochondria. So this is also important to know. So ultimately, at the center of it all is acetyl-CoA. As you can see, it is a center of attraction. Everything leads to acetyl-CoA. Everything leads to Krebs cycle and energy production. So whether it is amino acids, whether it is carbohydrate, or whether it is fatty acids or glycerol, everything has to go through the acetyl-CoA and Krebs cycle. Now, enough of biochemistry. Let us get on to the clinical medicine. But I think it is very, very important to know these basics. I mean, that is basically gist of biochemistry relevant to clinical medicine. So that's why I had to spend about 10 to 12 slides on that. So now let us see why and when do you suspect inborn error of metabolism. Though overall, each individual IEMs, we know about at least 700 to 800 IEMs so far. So has been discovered. Though individually they are very rare, but overall incidence of IEM is about 1 in 800 to 1 in 5,000. That is not very rare, right? And that is why it is important to suspect it. And also, if you look at the clinical findings in IEM, it's a very close mimic of common diseases like sepsis or CNS infections. CNS infections can cause encephalopathy. Sepsis can cause encephalopathy. And similarly, IEMs can cause encephalopathy. Sepsis can cause metabolic disease, metabolic acidosis. IEM can cause metabolic acidosis. So it's very, very important to have a high index of suspicion because, of course, sepsis and CNS infections are more common than IEM. But since they are the close mimic of sepsis and CNS infections, we should always have a high index of suspicion for IEM. So when do you suspect? whenever there is previous unexplained deaths in siblings, and if there is a case of sudden infant death syndrome in the family, particularly in infancy, you should always suspect IEM. Now, if there is a consanguinity, that's why probably the incidence of IEM is much commoner in South than in the North, is because we have a high degree of consanguinity. So when there is consanguinity, there is always a higher chance of having an autosomal recessive disease. So that is why you should suspect IEM if there is a history of consanguinity. And of course, if there is a recurrent presentations of acidosis, or the patient is recurrently getting sick with trivial infections, he gets cold, cough in one day, and next day he's very sick with respiratory distress, tachypnea, and acidosis, then you should definitely suspect IEM. And also, a lot of kids vomit multiple times, but they don't get into trouble. But if you hear a history saying that child vomited at 8, 9 o'clock in the night, went to bed without eating, and morning he was quite sick, that is a red flag sign that it may be an IEM, because just 1 or 2 vomiting should not make the patient so sick. And rapid deterioration with very few symptoms, a little bit of fever, 99, 100, and within 12, 24 hours, he is completely moribund. Think about IEM. And failure to thrive, particularly in the first year, if there is a failure to thrive, always suspect IEM. So these are some of the time when you should suspect IEM. How do they present? As I said, they're great mimickers of sepsis. They're great mimickers of CNS infections. So look out for those symptoms of sepsis and CNS. If something doesn't fit, think about IEM. Unexplained respiratory distress. That means, this is a very common presentation. A lot of times patients come with a deep and rapid breathing. We think that it is respiratory. Look at the saturations. They are so sick, but the saturation is 98, 99. Then think that this is probably metabolic acidosis, which needs further workup. And hypoglycemia with trivial infection. As I said, a lot of kids go to bed without eating or one vomiting, but they don't get sick in the morning. But next day, if they come 5 o'clock to the emergency room with seizures, always think of hypoglycemia. And if there is hypoglycemia with trivial infection, you always think of trivial fasting, think of IEM. Encephalopathy, we already spoke about. Any encephalopathy which is not explained by other reasons, think of IEM. Seizure disorder itself, seizure itself can be a manifestation of IEM. And of course, different IEMs can affect different organs. You can have galactosemia, tyrosinemia causing liver dysfunction. You can have storage diseases causing gradual neurological dysfunction. You can have fatty acid oxidation defect presenting with cardiomyopathy picture. So any organ dysfunction which is not explained by anything else, think of IEM. On examination, you get some clues where you will think that probably this is IEM. One is disproportionate encephalopathy. We see so many patients with sepsis. We see so many patients with meningitis. They are not usually so encephalopathic. Sepsis, even in the patient is hypotensive, we don't see them so encephalopathic. So if there is a disproportionate encephalopathy, think of IEM. Effortless tachypnea, we already talked about. Good air entry, but they're breathing fast, breathing deep, and saturations are well, then think outside the lungs and think of IEM as a reason for metabolic acidosis. And we know that sepsis can cause metabolic acidosis, but when the sepsis causes intense metabolic acidosis, it is usually because they're hemodynamically very unstable. But if you see a patient with severe metabolic acidosis with relatively preserved hemodynamic function, then think of inborn error of metabolism. Of course, organomegaly, depending on the IEM, you can have hepatomegaly, you can have splenomegaly, you can have, cardiomegaly, all those things. There are some skin clues. There are some diseases where you can have, it can be xanthoma, it can be just, rough skin. It can be seborrheic sort of picture. And breath odor. Breath odor, I'm not sure. In last my 22 years, I've never diagnosed any IEM with the smell of the breath. I mean, maybe it needs some special olfactory nurse. But as a postgraduate, you may be quizzed sometime about what smells like what. So I never remember this, and maybe you can go through the chart later. Clinical pointers to diagnose IEM. This is from IAP book. So basically, this is very important because if you have a cataract, it can suggest galactosemia and other things. It is just one example of what you look for. Corneal clouding can be suggestive of mucopolysaccharidosis. Cherry red spots in Tay-Sachs. Skin, as we talked about, alopecia. It can be a sign of biotinidase deficiency. Coarse kinky hair, Menkes kinky hair disease. And hepatosplenomegaly, we already talked about in storage diseases. Cardiomyopathy, we talked about in fatty acid oxidation defects. So all of these are sort of clinical pointers to various IEMs. Of course, sometimes when the patient comes with encephalopathy, we always think maybe it is infection, maybe it is encephalitis, maybe it is a bleed. We end up doing an MRI scan before even realizing that it may be IEM. And there are some neuroimaging clues in IEM which can give you away actually a complete diagnosis. For example, this particular MRI scan, as you can see, there are bilateral parietal loss of brain tissue, and also sometimes there can be subdural effusion. If you see this in a patient with delayed milestones, increased head size, then infancy, it is nothing but glutaric acidemia type 1. Similarly, you can have brainstem lesions in leaky encephalopathy. I don't have pictures of all those things, but and also you can have white matter changes in X-linked adrenoleukodystrophy, metachromatic leukodystrophy, or sometimes you can have symmetrical basal ganglia and thalamic involvement in mitochondrial disorders. So all of these can give you a clue about a particular IEM. Though I should say this is not a primary, I mean, in neuronal storage diseases, it can be a primary modality of diagnosing it actually. So once you suspect based on the presentation, based on consanguinity, based on previous sibling deaths, all these things, how do you investigate the suspicion? You suspect metabolic diseases, and then how do you start investigating? So while investigating IEM, you don't have to have a diagnosis to manage the IEM. We'll come to that later. You will know that, you don't have to know a particular type of metabolic diseases to manage an IEM patient. But the first tier investigations are very, very important because it will give you a clue regarding which type of IEM broad category it falls into. So at the minimum, you should do a blood glucose, ABG with lactate, ketones, whether it is in serum or urine. Serum would be better, but urine is usually good enough. Ammonia, of course, renal function test and liver function test may not be that important, but if the child is so sick, we end up doing it anyway. But liver function test can give a clue in certain diseases which affect the liver. So blood glucose, ABG, ketones, ammonia, they're very, very, very important. Particularly blood glucose before you even give any intervention to the child, in the sense before starting the IV fluids, because missing an hypoglycemia will derail your thought process and will take you somewhere else when you are dealing with inborn error of metabolism. So a sick child comes, almost now blood glucose is like a fourth or fifth, whatever you call it as fifth vital signs. So after your heart rate, temperature, pulse oximeter, blood pressure, do blood glucose in all sick patients. I mean, it goes without saying, anybody, whether it is seizure, sepsis, whatever. ABG with lactate, ketones, ammonia, and this thing. Now, few things about ammonia. Ammonia should be sent right away, and it should be a free flow sample. You cannot be squeezing the hell out of the patient to get ammonia levels. And if you leave it, if you take that way, and if you leave it for even 30, 40 minutes in the outside room temperature, the ammonia will be high. And again, it will derail your thought process regarding the possibility of which IEM we are talking about. And also at the same time, second tier investigations, of course, they take time, but it is very, very, very important to have the specimen for the second tier investigations when the patient is acutely sick. Because as I said, most IEMs, they have a variable phenotype. They can be mild, moderate, severe. Sometimes when you do this test, when they are compensated. When they're not decompensated, they can be completely normal. So it is very, very important to take the second tier investigations during the first tier investigation. Don't need to send it right away, but freeze the blood. Freeze 2 ml or 4 ml of serum. Take the first collected urine sample and freeze it. This is like a golden sample because it will, you may not need it. It may turn out that this patient only has DKA or something. You may not need to send it, but you cannot send it after correcting the metabolism. You have to send it when the metabolism is deranged. So second tier investigations, plasma acyl carnitine analysis, urine organic acids, plasma urine amino acids, plasma CSF lactate, all those things can be done. Of course, CSF is only in certain situations like mitochondrial disease, we may need it, but otherwise, about 4 ml of blood serum and about 10, 15, 20 ml of urine. Please, please, please freeze it. It's a very, very important sample. Now, and also take filter paper for newborn screening. That's also very, very important because it is easy to preserve it. It can be left at the room temperature and it can be analyzed even later. So 3 things: 4 ml of blood, some ml of urine, and a newborn screening on filter paper. Now, what about this? One of the commonest mistake people do is sometimes ask for amino acids and organic acids. Always remember, it is the urine organic acids you ask and serum amino acids you ask, not the other way around. There is a physiological reason for it. Organic acids, sorry, let's talk about amino acids. So amino acids have a very, very high tubular reabsorption capacity, unless you have a Fanconi syndrome, in the sense tubular defects. So even if the serum amino acids are very high in the blood, if it is filtered into the kidney, if the kidneys are fine, if they don't have tubular reabsorption problem, everything will be reabsorbed. So you may not pick up any urinary amino acids, even if there is an amino acidopathy. So never send urine amino acids unless you are thinking of Fanconi syndrome causing tubular reabsorption problem in amino acids. In most of the inborn error of metabolism, you don't need to send urine amino acids. You send serum amino acids. And as far as urine organic acids, most of the organic acids in the blood are actually mopped up by the carnitine. They are in the form of acyl carnitine. So if you ask for serum organic acid, nobody will do it. Instead, you should ask for serum acyl carnitine levels, because again, urine organic acid, organic acids in the organic acids have a very, very low tubular reabsorption. So even if there is a small increase in the blood, it gets filtered into the urine. So it is important to catch it in the urine. So always remember, urine organic acid, serum amino acids. Urine amino acids only when you suspect there is a leakage of amino acids in the kidney, which is Fanconi. Okay. So this is very, very important to know. And we always know that, urine organic acids are sent after the freezing the specimen. Next day you can send it. Again, sample should be frozen. So based on the first tier investigations, when I say first tier investigations, blood glucose with lactate, ketones, and ammonia, only 4 things, we should be able to approach the inborn error of metabolism. One is how to approach the metabolic acidosis, how to approach hypoglycemia, and how to approach hyperammonemia. In metabolic acidosis, 2 types of acids mainly. Of course, organic acids is a broader term. Lactic acids, ketones, which are specific acids, and other organic acids. That is how we approach the metabolic acidosis. I don't need to go through this. You all know the first thing, whenever the patient has metabolic acidosis, the first question you ask is, what is the anion gap, right? So if it is a normal anion gap, that means if you are losing bicarb somewhere. And there are only 2 places where you can lose bicarb in the body, nowhere else. One is the kidney, other is the gut. If the patient is acidotic because of diarrhea, you will know by history. He would have passed 10, 15, 20 stools, he would be severely dehydrated. There's no way missing it. And of course, if the child is very acidotic, but the anion gap is normal, it is renal tubular acidosis, unless you can explain it by the gastroenteritis. So let us not go into what is the normal anion gap. I mean, everybody knows what is normal anion gap. Now, what we are worried is the increased anion gap. Even in increased anion gap, not every increased anion gap is IEM, because we know it can be methanol ingestion. It can be uremia, patient may be in renal failure. It can be DKA, which is, I mean, you can call it as inborn error of metabolism, but it is not really. It is an acquired sort of, later. So on paracetamol poisoning, which is very common in pediatrics, iron poisoning, isoniazid toxicity, paraldehyde toxicity. So there are many other reasons for increased anion gap. But if you rule out all these things, increased anion gap acidosis is IEM. After ruling out the other causes for increased anion gap. So the first thing you should do when you have metabolic acidosis is to look at the anion gap. Now, high anion gap metabolic acidosis, that is called HAGMA. Of course, we already spoke about most of the time we do have lactate available, and also we have ketones, serum ketones available. But even if you don't have ketones available, you can just serum ketones available, you can just do urinary ketones, right? Now, depending on the lactate levels, depending on the ketones level, you can divide it into high ketone, low lactate situation, high ketones, high lactate situation, low or no ketones with high lactate situation, and no or low ketones with low lactate situations. Now, no ketones and low lactate, most of the time, it is a normal anion gap acidosis. So that will be RTA or something else. You know, very rarely, very rarely in metabolic diseases, you have low ketones, low lactate, but high other organic acids. Very rare, right? So we'll not talk about that, but the rest of the other three we'll talk about. So first, high ketones and low lactate. Now, the moment you hear high ketones, right? We talked about biochemistry. Think about ketones are produced by fatty acids, right? Of course, there are some ketones which are produced by some amino acids, but most of the time body produces ketones, majority of the ketones by fatty acids. So if you have high ketones, one metabolic disease you can rule out is fatty acid oxidation defect, right? You can rule out. Of course, there may be an exception. There are very few exceptions where you can have not high ketones, maybe some ketones with long chain fatty acid, the terminal part, but don't worry about it. But 99% of the time, if you have ketones, particularly high ketones, you are ruling out fatty acid oxidation defect. Now, low lactate, any mitochondrial disease, because lactate has to be taken up and has to be put through Krebs cycle and metabolized. So mitochondrial oxidation or electron transport chain is ruled out if you have a low lactate. So if you have a high ketones, low lactate, and metabolic acidosis, most of the time, it will be organic, most probably organic acidemias, other organic acidemias. Okay. Of course, this may be the same situation in your DKA also. I'm talking about just IEM after ruling out all the other reasons for high anion gap acidosis. Now, what about if high ketones and high lactate, right? So now again, if you have ketones, high ketones, your fatty acid oxidation defects are ruled out, right? So in acidosis, first thing you do is look for ketones, if not urine ketones. If it is negative, then most likely you're not dealing. If you see ketones in the urine, that means your fatty acid oxidation defects. Or if you don't see, so if you see high ketones, it is ruled out. If you see low ketones, we'll come to that later, right? And high lactate. Now, when you see high lactate, either it is, we will come to the approach of high lactate separately later. But if you see high ketones and high lactate, that means lactate is not being utilized properly. So it may be possible mitochondrial disease. It may be possible pyruvate carboxylase deficiency, because remember this equation, pyruvate to pyruvate is converted to oxaloacetate to enter citric acid cycle by pyruvate carboxylase. So if you have high lactate, this reaction is not happening. So instead, pyruvate is converted to lactate by lactate dehydrogenase. So if you have high ketones and high lactate, possible mitochondrial disease, possible pyruvate decarboxylase deficiency, or other organic acidemia with high lactate, because when you have organic acidemia and dehydration, the dehydration itself, shock or hypotension itself can cause high lactate. So that is one way of looking at high ketones and high lactate. Now, what about if you have low ketones and high lactate? Okay. So when you have an acidosis, I will also come to hypoglycemia. When you don't have glucose, the body goes first to glycogen, then gluconeogenesis, and then within 12 hours, fatty acids. If there are no ketones and the patient is very acidotic, that most likely it may be possibly fatty acid oxidation defect. So ketones are very, very important. Urine ketones or serum ketones are very important to look at when you are dealing with an IEM, both from the perspective of acidosis and also from the perspective of hypoglycemia. The hypoglycemia part will come to later. Now, if there is low ketones, high lactate, if it is also associated with hypoglycemia, there is almost 95% possibility that it is a fatty acid oxidation defect. You don't have to think about anything else, right? And if it is not associated with hypoglycemia, then the possibilities are more. It may be pyruvate metabolism defect, because that is why it is causing high lactate. And lactate, I mean, the ketogenesis, ketolysis are not affected. So that's why there is no ketones. And mitochondrial disorder also can cause high lactate. Of course, a lot of mitochondrial disorder also can have little bit high ketones also. This is the same thing. I don't know whether you can see it, but so I will skip it. Basically, I've summarized this chart in the last 4 slides. So how to approach, metabolic acidosis. Let me see if I can zoom. Yeah.
Sir, it's visible, sir.
Visible, no? Okay.
Yes, yes.
Actually, it's not visible to me. So, okay, sorry, I'll just check. So basically, if you have metabolic acidosis, the first thing you do is you see for whether it is ketotic or hypoketotic, right? You can do urine, you can do serum if you have. If it's hypoketotic and normal lactate, it's 95%. There's only one thing, which is basic, it is, if it is acidosis, but there is no ketones and glucose is normal, this is usually renal tubular acidosis, because the anion gap will be normal. Now, if you have hypoketotic, but you also have high lactate and hypoglycemia, then 95% it is fatty acid oxidation defect. Because when you are hypoglycemic, the normal response is to break down the fat into ketones and supply it to rest of the body, which is not happening. That means fatty acid oxidation defect and related causes, right? So this is what you measure. PAC. You're seeing the pointer also. Are you seeing the pointer too?
Yes.
Oh, okay. Sorry. Yeah. So that is how you do if there is a ketotic, hypoketotic. I mean, ketones normal or low, then normal lactate or hyperlactate. If ketones are present, and it is normal lactate and also hypoglycemic, that means, the patient, there is some issue with gluconeogenesis. There is some amino acid somewhere, there is a breakdown. So it may be one of those organic acidemias. Or if there is also hyperammonemia along with that, it can be organic acidemia. If hyperammonemia and hyperlactatemia and ketosis and metabolic acidosis, if all of these are there, it's most likely pyruvate carboxylase deficiency. So it's a very important chart. You can take a screenshot or something, and probably it is there in a lot of textbooks anyway. So this is one way to look at it, but think why it happens, right? For example, hypoketotic. The moment you say hypoketotic and acidotic, look at the ketones, and look at the glucose. If the glucose is low and patient is not producing fatty acids, releasing fatty acids to produce ketones, then it is fatty acid oxidation. So that is how you should think. Is it going forward?
No, sir.
Okay, yeah. So another test we do sometimes, but not every lab has this available. One is to look at lactate pyruvate ratio. It's a very important thing because we will come to that how to approach lactate little later. Lactate pyruvate ratio is very, I mean, some labs can do lactate pyruvate ratio, but again, the specimen has to be processed very quickly, and not every lab has facilities to do it. But if you have the facility, you can do it. The advantage is you can rule out a lot of, you can separate lactate when the lactate pyruvate ratio is high and lactate pyruvate ratio is low. We'll come to that later. But in this slide, I just wanted to bring to attention, when lactate is produced when there is less oxygen available, right? So NAD to NADH, so by lactate dehydrogenase. Pyruvate is produced when oxygen is more available. Then what happens? Pyruvate enters the citric acid cycle when more oxygen is available. When oxygen is not available, whether it is hypoxemia, sepsis, I mean shock, whatever, lactate is produced, because lactate is a reduced state, pyruvate is a oxidized state. Anyway, we'll come to how to approach lactate pyruvate ratio a little later. So yes, right here, yeah. So basically, how do you approach isolated lactic acidosis? If you have the facility, you can do this. If you have lactate to pyruvate ratio more than 20, so what does it mean? It means there is more lactate. More lactate means it is an anaerobic metabolism. So it can be from your hypoxemia, it can be from your carbon monoxide poisoning, it can be from cyanide poisoning, it can be shock. And in inborn error of metabolism, high lactate to pyruvate ratio means it is one of the electron transport chain defects, right? There is nothing else. If you have everything else is normal and isolated lactic acidosis, high lactate to pyruvate ratio, you have ruled out other acquired diseases like shock, cyanide poisoning, carbon monoxide poisoning, and all those things, then it is an electron transport chain defect. But if you have lactate pyruvate ratio less than 20, that means there is more pyruvate than lactate, then it is one of the pyruvate metabolism defect. It can be pyruvate decarboxylase deficiency, pyruvate carboxylase deficiency, and all those things. So how do you differentiate the two between pyruvate decarboxylase deficiency? In pyruvate decarboxylase deficiency, you don't need to remember this, but when you give glucose, that we do always in any patient with IEM, the lactate increases with glucose infusion. That is pyruvate decarboxylase deficiency. If your lactate decreases with glucose infusion, then it is PC deficiency or PE-PCK deficiency. Don't worry about that, but just a general outline. If you have the facility to do lactate pyruvate ratio, this is how you approach. And the other important thing is non-metabolic sources of hyperlactatemia are not usually accompanied by ketosis. For example, we see so many patients in shock, so many patients who are hypoxemic. None of those patients will have ketosis. So if you have a lactate, high ketones, think of IEM rather than other reasons for lactate, high lactate. Of course, there may be small amount of ketones in a patient, septic patient who has been vomiting or who has been not eating for a while, but very high ketosis, very high lactic acidosis is usually IEM rather than other reasons for hypoxemia, shock, and other things. Now, the second approach is, how do we approach the hypoglycemia? Before that, we need to understand there's a little bit of biochemistry in this. We all know that when we all need constant supply of glucose, that's why we eat almost every 4 hours, 6 hours, 8 hours, whatever. And when we fast for more than, even during the night, when we fast more than 4 or 5 hours, slowly glycogenolysis happens. And after 4 to 6 hours, gluconeogenesis happens. And later around 10 to 12 hours, your ketosis, fatty acid is called up to produce energy. So this is what the normal process is. So when you approach hypoglycemia, two things you should know. Question: either is it a fasting hypoglycemia or postprandial hypoglycemia? Again, ketones at the center of it. Ketones present or ketones absent. How is it important? As I said, looking at this slide, if, for example, if you have a glycogen storage disease, right? As I said, usually glycogen is called into action within 3 to 4 hours. First 4 hours of postprandial period, you use glucose, whatever you have ingested, and then glycogen is called to produce glucose. So with intermediate type of fasting, if you have hypoglycemia, it is mostly gluconeogenesis or glycogenolysis pathway defect. Whereas if you have fasted for 8 hours, 10 hours, which is usually overnight fasting, and you are hypoglycemic and fatty acids do not come into picture to produce ketones, that is hypoketotic, hypoglycemia, fasting, it is usually fatty acid oxidation defect. So putting together the time frame, for example, if you have just eaten 2 hours, 3 hours, 2 hours ago, and suddenly you become hypoglycemic 2 hours after eating, that is most likely hyperinsulinism, because your insulin levels go up after eating. So if you have hyperinsulinism, your hypoglycemia is usually postprandial. So postprandial hypoglycemia is usually suggestive of your hyperinsulin state. Hypoglycemia after a fast, intermediate duration fast, 4 to 8 hours, is usually a glycogenolysis or gluconeogenesis pathway defect. Whereas hypoglycemia with no ketones happening 8 hours or 12 hours after the last meal is usually fatty acid oxidation defect. And please remember, in hyperinsulinism also, when you have hypoglycemia, there will not be any ketones in the blood, in the urine or blood. That is because insulin actually prevents prevents fatty acid oxidation, right? So that is also hypoketotic hypoglycemia. But the hypoglycemia with ketones after 12 hours of fasting is usually fatty acid oxidation defect. If it is postprandial, it is usually hyperinsulinism. And of course, if you have an hyperinsulinism, looking at the patient, you know that the patient is chubby, patient is very quite anabolic. So that is also one differentiating factor. Sorry. Some issue with this. Yeah. Okay. So summarizing that, hypoglycemia with absent ketones, right? So it almost rules in your fatty acid oxidation defect unless you are thinking of hyperinsulinism clinically, right? So how do you this thing? That's why whenever there is hypoglycemia with absent ketones, one of the other samples you should take if you have a suspicion is the insulin levels. You don't need to send it, but take the sample and keep it for insulin levels. And if you have hypoglycemia and ketones are present, then the whole gamut of things which produces glucose, glycogenolysis, gluconeogenesis defect, ketolysis defect. So all these things will come. Ketolysis defect, not ketogenesis defect, to break down ketones. Because when you have hypoglycemic, normally you should produce ketones and you should lyse ketones to get energy, which that doesn't happen. Then it is this type of defects. Of course, if you have hypoglycemia, ketosis and lactic acidosis can also happen with glycogen storage disease, because basically all the pathways lead into that. No? And if you have hypoglycemia, ketones are present, hyperammonemia and hypoglycemia, all things, which is a classic presentation in a newborn with amino acidopathies or organic acidemia. They have hypoglycemia, they have ketosis, they have acidosis, hyperammonemia and hypoglycemia, and a little bit of lactic acidosis also probably. So again here, I don't know how much it is visible. Basically, I've already spoken about all these things. Hypoglycemia, first thing you should do is ketones. Look at ketones and also see if it is associated with hyperammonemia, because hypoglycemia with hyperammonemia with acidosis, most of the time it is amino acidopathies and organic acidemias. And also, other than ketones, also look at if there is hepatomegaly, because if it is a hepatomegaly, most of the time it may be glycogen storage disease. So looking at all these pictures, you can come to a fair bit of conclusion, like what exactly are we talking about. So this is hypoglycemia. This is for whatever resource poor settings you are. The minimum you can do is this. You may not have a blood gas. You may not have lactate. You may not have serum ketones. You may not have anything, right? Of course, blood gas you will have because you see acidosis. Even if you don't have, clinically you say this patient's respiratory distress is non-respiratory, probably has acidosis. Simple thing, you can see this, is it? It's visible.
So bit
Yeah.
blur,
So
sir.
once you have hypoglycemia, all you have to do is a Benedict test, which we all did in biochemistry, right? For reducing substance. If there is non-glucose reducing substance, you do glucose is absent, but Benedict test is, non-glucose reducing substance is present, then it's most likely galactosemia or tyrosinemia. If hypoglycemia is there and non-glucose reducing substance is absent, that means it is glucose, and ketones are low, then it almost rules in your fatty acid oxidation defect. But if ketones are high, it will open up all gamut of possibilities. If you have other facilities like elevated lactate, abnormal urine organic acids, and normal urine organic acids, then you go into these parts, right? So the minimum you can do for hypoglycemia is urine ketones and urine reducing substance. If you do that in newborn, in infancy, you can pick up galactosemia, you can pick up tyrosinemia, you can pick up fatty acid oxidation defect if the ketones are absent. So this is quite simple even in strained environment. Now the third thing we want to look at, we have time, Dr. Nagalata. I can stop it whenever you want.
No, sir. We can go ahead, sir.
Sure. Okay. Now the next thing is approach to hyperammonemia. Of course, when you want to know hyperammonemia, you need to know the urea cycle. So basically, urea cycle happens. Part of it happens in mitochondria, part of it happens in cytosol. You know that ammonia and bicarbonate combines, carbamyl phosphate, citrulline, arginosuccinate, arginine, ornithine, and citrulline, this cycle. And as a result of that, urea is produced, and urea is excreted in the urine. Now, the urea is excreted and urea is converted to ammonia and carbon dioxide in certain tissues. We will not go into that, but yeah, so urea is excreted. Always remember, compared to all other things we have discussed so far, if it is an isolated hyperammonemia without metabolic acidosis, it is urea cycle defect. Urea cycle defect do not cause acidosis except only one type of urea cycle defect, which is arginosuccinate lyase deficiency, which is because arginosuccinate acid is an acid. Other than that, all urea cycle defects, all of them do not cause acidosis unless there is some other reason for acidosis. So pure urea cycle defect is usually have a metabolic alkalosis, and unless it is an arginosuccinate lyase deficiency, or of course, not just urea cycle defects causes hyperammonemia. We have gone through that, right? Even your organic acidemias, amino acidopathies can cause hyperammonemia. How do you differentiate? Hyperammonemia caused by urea cycle defects is usually 300, 400, 500, that level. If you see 100, 150 and metabolic acidosis, it is not urea cycle defect. It is probably hyperammonemia associated with other diseases like amino acidopathies or your organic acidemias and all. Okay, so if it is very high ammonia, it's usually urea cycle defect. If there is no acidosis and severe hyperammonemia, it is most 95% of the time it is urea cycle defect. Now we will not go into the details why organic acidemia causes hyperammonemia, but just to let you know, because hyperammonemia is caused in organic acidemia because a lot of these accumulated organic acids inhibit certain enzymes in the urea cycle defect. And of course, there are lots of amino acids here, right? You have arginine here, you have ornithine here, citrulline. If any deficiency of these amino acids happen, for example, if you lose a lot of amino acids in the kidney because of Fanconi, there are these numbers are very low, then it can cause secondary hyperammonemia. But that is a rarer condition than urea cycle defect. Mitochondrial fatty acid oxidation also can cause hyperammonemia, but again, it will not be very high. It will be borderline 100, 120 range, 150 range, because the mitochondrial fatty acid oxidation disorders produces certain metabolites which inhibit urea cycle. So basically, all hyperammonemias are not urea cycle defect, but very high hyperammonemia always suggests urea cycle defect. Hyperammonemia without metabolic acidosis always suggests urea cycle defect. Okay. Now, if you look at this chart, you can almost diagnose where exactly is the defect depending on your other test, which will come to later. But when you send serum amino acids and urine organic acids, if the citrulline level is very high, it is mostly the problem is here, right? Anything after citrulline. But if the citrulline level is very, very low in urea cycle defect, the problem is either OTC deficiency or CPS deficiency. How do you differentiate between CPS and OTC deficiency even before your gene testing? You know that carbamyl phosphate, if it accumulates, it's converted to orotic acid. So if the orotic acid is very, very high, that means the OTC deficiency. If there is no orotic acid in the urine organic acid profile, then it is usually CPS deficiency. So in that way, looking at this urea cycle, you can actually diagnose where exactly is the pinpoint, where exactly is the urea cycle defect. So again, approach to hyperammonemia, as I said, first age of onset, if it is within 24 hours, I'm sure there are some neonatologists here. So if hyperammonemia happens within 24 hours, and if it is a preterm child, don't be too worried in the sense, I mean, it can be urea cycle defect, sure, but there is something called transient hyperammonemia of the newborn. The cause is exactly not known, probably some enzyme, but it is usually transient and they get better by themselves. If it is a term child, and if there is organic acid or fatty acid oxidation defect is a possibility, because within 24 hours, if there is not enough load of protein given up from outside, which causes your urea cycle problem. So within 24 hours, if the term baby, if it develops hyperammonemia, borderline hyperammonemia, most of the time it is because of the organic acid or fatty acid oxidation defect. More than 24 hours, depends again, look at acidosis or ketosis. If the ketosis and acidosis are present, it is usually because of organic acid and fatty acid oxidation defect causing little bit of hyperammonemia. Whereas if it is a urea cycle defect, ammonia will be very, very high. And then, as I told you, you look at the plasma citrulline. If the plasma citrulline is absent, that means the disease is either this or this, right? And then look at the urine orotic acids. If the urine orotic acid is high, then it is OTC deficiency. If it is urine orotic acid is low, then it is CPS deficiency. In that way, and also if the plasma citrulline is high, then the deficiency is here, that is AL deficiency. If the plasma citrulline is very, very high, then it is probably AS deficiency. So like that, you can actually tease out what exactly the disease is before even actually checking further enzyme levels or gene testing. So whatever the reason, the approach to initial emergency management is the same. As I said, you don't need to diagnose, but it is important to pinpoint where exactly we are heading. But approach to initial emergency management is very, very important. And you don't need to have a pinpoint diagnosis to manage a patient. All you have to do is simple ABCs. But please remember, just because you see a blood gas of 7.0 metabolic acidosis, do not jump and intubate the patient if the neuro condition is reasonable or respiratory condition is reasonable. The reason is when they are acidotic and breathing heavily, deep and compensating, you actually, if you intubate them, you will not be able to compensate through the ventilator. You may cause problem. Of course, I'm not saying never intubate a patient with IEM, but if you can manage without intubating a patient, you should manage without intubating a patient. Just for looking at the pH, you should not intubate a patient. You should keep them NPO because, as I said, most of the diseases are triggered by catabolic pathways. So you should avoid, and also we don't know what we are dealing with. So you should not be giving extraneous amino acids which cannot be metabolized. You cannot be giving extraneous fat which cannot be metabolized. So keep the patient NPO. And of course, they are usually kept NPO because they're quite sick. Correction of dehydration is very, very important because most of these patients, because of acidosis, they would be dehydrated because a lot of respiratory losses of water. this is one situation where on sepsis we don't use bicarb, but this is one situation where you can use bicarb, not the bolus doses of bicarb, but generally what we do is we prepare the fluid with bicarb so that it comes to half normal saline or normal saline concentration and give it. The most important is to arrest the catabolic pathway. How do you do that? So basically give glucose at minimum of 8 milligram per kg per minute or up to 15 milligram per kg per minute. In fact, 40 to 50% of the calories requirement should be given by glucose. Intralipids, only if you are certain that you're not dealing with fatty acid oxidation defect. If you are suspicious of fatty acid oxidation defect, don't give intralipid, obviously, right? And if you are giving higher glucose and if the patient become hyperglycemic, don't hesitate to start insulin, because insulin is anabolic. It is always important to make them anabolic because the catabolism is what triggers these patients to decompensate. Treat the infection, very, very important. Unless you treat the infection, the catabolic process will not. So it is better to err on the side of caution and start antibiotics, suitable antibiotics, depending on the focus. Correction of severe acidosis and hyperammonemia. Hyperammonemia, will come to that, how to deal with hyperammonemia separately, but hyperammonemia, if it is reasonable, you can manage with drugs. But if it is more than 500 and with acidosis, it is better to do dialysis, hemodialysis. Peritoneal dialysis is not so effective. But if you don't have hemodialysis, you can still do peritoneal dialysis. And there are times when we didn't have both. We have even done exchange transfusion. But that is not an option nowadays. But if you are forced to do it, you can't do hemodialysis, you can't do PD, you can actually try doing exchange transfusion. Metabolic cocktail, we know why we give it, right? What we give: B1, B6, B12, riboflavin, folate, biotin. If you look at all these biochemical pathways, a lot of these pathways have cofactors, which can be B1, B6, thiamine, B6, B12, riboflavin, folate. They're all cofactors. So it is important to increase their levels so that if it is cofactor related defect, it can be corrected. Carnitine we talked about. Carnitine is a scavenger for fatty acids. So, and also it helps in pushing the carnitine into the mitochondria. So any suspected metabolic diseases, you should supplement carnitine. Coenzyme Q are also given sometimes because, mitochondrial diseases, electron transport chain coenzyme Q deficiency can cause problems. So all of these, are done usually to correct, irrespective of what your diagnosis is. You don't need to know what sort of disease it is to start all this treatment. Always I advise any PICU, always have a packet of all these things in hand. You make a small packet, small box with all this, because if the patient comes in the middle of the night at 8 o'clock, 10 o'clock, you won't be sending them to pharmacy to pick all this. And by the time they come back, it will be 12 hours. So always have 1 doses of each in your PICU and start this, because a lot of times, if these are cofactor responsive metabolic diseases, they work tremendously well, right? And when do you start feeding them? Once toxic metabolites have normalized, ammonia has come down, acidosis is better, you can reintroduce the protein, but at lot less, not like 1 to 2 milligram, but 0.5 gram per kg per day. And of course, if you have a suspicion of amino acidopathy, probably you should wait and for particular amino acid free formulas. But lipids can be given after you rule out fatty acid oxidation defects. And for patients who are able to tolerate enteral feeding, protein restricted preparations can be given. But if you have not got it, at least reduce the protein content of the food. Of course, the definitive treatment will come to later, depending on what the specific diagnosis. It can be transplantation, it can be enzyme replacement, it can be gene therapy. All those things we are not going to talk about, because we are going to restrict ourselves to what happens in the ICU and acute care settings. Okay, so approach to hyperammonemia. If you have hyperammonemia, first thing is, as I said, you should stop giving any extraneous proteins. And of course, even if you don't give extraneous proteins, the body will catabolize some protein and cause hyperammonemia to increase. So you have to give good amount of calories glucose and intralipids, because so that the bodies do not use amino acids for calories. Once you do that, and then next thing you do is ammonia scavengers, that is sodium benzoate or sodium phenyl bitrate. You know how it works. Sodium benzoate mops up the glycine, and sodium phenyl bitrate mops up the glutamine, which are the two most important storehouses of ammonia. So they mop that up and help. So irrespective of where the defect is, it works. And depending on where the defect is, for example, if it is a N-carbamyl N-glutamate, can be given if the first step is the problem. If your first step of, if the first step, carbamyl phosphate synthase, if it is a problem, you can give this because this works as a accelerator for that enzyme. Administration of arginine, you know that arginine can only be given if you are, so if arginine can be only given, you can see here, if you give arginine anywhere else, for example, if you have arginine cannot be metabolized, and if you don't know if the arginine is high or low, if you are suspecting here, don't give arginine. Other than that, most of the urea cycle defect, arginine can be given, because arginine again mops up. You can see here arginine to urea and ammonia here directly. That is how arginine can mop up the ammonia and remove the produce urea. So unless otherwise not indicated, arginine can be given. Of course, if it is more than 500, 600 levels of ammonia, you are going to do hemodialysis. Now approach to amino acid metabolism. It is again another different category altogether, but three important basic things you should know. Amino acid metabolism can be because the first part of the pathway, for example, phenylketonuria and MSUD. This is the first pathway where the amino acids are not metabolized. So those accumulate and cause encephalopathy. Second, down the line, if you have problems, once in the amino acid catabolism, down the line, if there is, then it causes organic acidurias like your methylmalonic acidemia, isovaleric aciduria, or propionic acidemia. And of course, you can have amino acidopathies because of the renal tubules loss of amino acids. That is, then you can diagnose that by doing urine amino acids. That is the only time you do urine amino acids. Otherwise, there is no role for doing urine amino acids for IEM. So approach to ketosis, we already talked about. If there is ketosis, that rules out your fatty acid oxidation defect. I want to reiterate that because it's a very important thing, very simple thing to do at the bedside. But remember, ketosis can happen in any other IEMs, not just ketolysis defects. It can happen in any other IEM. It can even happen in a patient who has come for LRTI or pneumonia. You do ketones, it will be positive. That is because of the fasting ketones, which is a normal response of the human body for fasting or for vomiting. So the last three slides here, because I am sure PGs, you have all ordered newborn screening, and it's important to know what it shows. So basically, when you order newborn screening, whether it is by blood or from the filter paper, this is what you see, the first page. Amino acid disorders, normal. Urea cycle disorders, normal. Organic acid or fatty acid disorder, normal. How did they decide this? It is not that they have done hundreds of genome testing and decided. No, it is based on the next page. So basically here you can see there are two things they do: acyl carnitine profile and amino acid profile. Acyl carnitine, why acyl carnitine? Why not organic acids directly? Because as I told you, organic acids are tubular reabsorption is very low. When you have organic acids in the blood, if the kidneys are fine, it gets excreted enormously. So you have to catch the ones which are linked to, ones which are bound to carnitine. That is why we do acyl carnitine level, basically for organic acids. And amino acids profile, as I said, serum amino acids is done. And depending on the numbers, so basically, depending on the pathway, they will decide whether there is amino acid disorder or organic acid disorders or fatty acid oxidation disorder. So this is the second page of your report. And the third page, will give you a list of about 50 or 56, 62 diseases. It can be 108 also. Extended test can have 108. And this is purely based on the previous pages. Depending on what all is raised, and if you put all of those in those pathways, then you will conclude that he may have one of these diseases. So basically here, it is a final report. This is your profile of, in a way, serum organic acids, because serum acyl carnitine profile and amino acid profile, and then the actual disease. So once you make this diagnosis and manage the patient, I mean, we are not worried about where particular enzyme is defective, but it is important to know, because one, to assess the risk of next pregnancy, and also certain treatments can be given better. For example, I showed you in urea cycle defect, there are certain urea cycle defect you should not give arginine, right? So arginine can be detrimental in certain urea cycle defect. So it is important to know specific enzyme assay that can be done either in skin fibroblast or liver biopsy. For example, carboxylase activity, lysosomal enzymes, and all those things. But generally, it is not easily available. Not every lab or every city does it. Of course, nowadays, thing is about genomics and exome sequencing. You can diagnose if you know that certain particular mutations causes certain disease. But we know that we don't know all the mutations which can cause a particular disease. So that is why now what is coming up is a metabolomics, which is very, very promising. So basically what it is, as I told you, in newborn screening, they check for about 20 or 25 organic acids and about 10 or 12 amino acids. And they try to put together and diagnose. Whereas in metabolomics, basically you take 2 ml of serum and you basically create a database of every chemical that is present in the blood. So when you create a database of every chemical that is present in the blood, and then you can put it in a computer and say, okay, this is particular enzyme here is abnormal. So that means you are checking for more than 700, 800 or 900 metabolites and check and see whether, so this is a promising one, because this will pinpoint the exact diagnosis of IEM, and also it will tell you the severity of the disease and all those things. So it is not yet easily available, but it is something in the pipeline. So prevention is better than cure. Universal newborn screening is a pipe dream. A country like India, we cannot, see, all screening programs are useful only if it is universal. But unfortunately, with 140 crore people, we cannot offer newborn screening to every baby who is born. But as a clinician, at least what we should do is, we should definitely insist on getting a newborn screening if there are 2 things: unexplained sibling deaths or consanguinity. Consanguinity is quite high in India. So in your first newborn visit, if you can ask for consanguinity and previous sibling deaths, if it is there, worth investing 3,000 or 5,000 rupees for as comprehensive newborn screening as possible. Not just 6 diseases, comprehensive newborn screening. So concluding, few very basics of biochemistry. I know that I have taken almost 1 hour, 15 minutes. I probably overran. This is, I wanted to do some cases, but I guess we already overshot the time. Very basics of biochemistry is important to know. You don't need to do the whole of Harper biochemistry, but it is important to know the gross biochemistry, what happens to understand IEM. High index of suspicion is very, very important because there are mimics of normal diseases. Stabilization following some general principles. You don't need to know the exact diagnosis to manage IEM, and you don't need hi-fi things to manage IEM, at least in an acute phase. Systemic approach with few initial investigations, focused investigation following the clues and initial investigations, and of course, prevention through newborn screening. I'm open for questions if there is any. Sorry, I overshot. I tried to make it as short as possible, but I guess, yeah.
No, sir, we are getting messages that I got that it was an excellent session and it was a simplified form. I think Ashray only should be telling. He's the one who suggested the topic and wanted the topic.
Okay. Yeah.
So he'll give his feedback as a postgraduate.
It was really helpful, sir. Like the way it was summarized and the way how to approach was really helpful, sir.
See, normally, I don't know whether you guys do. When I was in MD, I used to skip those chapters repeatedly. Only before the exam for short notes we used to prepare. I don't know whether things have changed now. So, and I know IEM more than now more than when I was doing my MD. Honestly, after taking care, and I know more biochemistry than I was in first year MBBS. That is because of taking care of IEM and thinking about it.
Yes,
So
sir,
it is always a very intimidating to read IEM when you're a PG. Definitely. Yeah.
Yes, sir. I think Dr. Deshpande has mentioned that it was an excellent session, one golden lecture to be preserved. It is available on YouTube for all of us to revise. I think most of them would actually go back to recording. I myself missed sections, so probably I will go through the sections and then get back to you. So thank you so much.
Sure,
and
sure,
probably next time we'll have a quiz or a case series. Actually,
Yeah. Quiz should be fine.
and they do have OSCE on these IEMs. Probably a short form or a quiz kind or an OSCE session. Probably we can do based on the similar topics subsequently once sir comes back.
Sir has also spoken about part 2, so all of us are
yes.
IEM returns. Huh?
Yes. No, now it is all KGF part 2, so this IEM part 2,
okay.
We'll get back to sir, and thank you so much for this session. So thank you.
Sure. Thank you very much.
Thank you so much.
Thanks a lot. Yeah.
Bye, sir.
Thanks. Bye.
Looking forward to cases is the message.
Sure. Maybe in June, after June.
Yes, sir. Yes.
Sure.
Okay.
Thanks a lot. Thanks.
Yeah, bye, sir.